Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chu-Manchu, and I'm joined tonight by my co-host Sam, as well as our producer, Dr. Callie Marshall. Say hi, guys.
Hello.
Hey.
Tonight is our guest, Dr. Carmina Erdei, to discuss care of the NICU graduate. But first, Sam, do you want to remind us what the show is all about?
Sure, I'd love to. So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Carmina Erdei. Dr. Erdei, MD, holds triple board certification in pediatrics, neonatal perinatal medicine, and developmental behavioral pediatrics. She is a neonatology faculty member in the Department of Pediatrics at Brigham and Women's Hospital. She is also the medical director of the Growth and Development Unit, a subunit of the Brigham and Women's Hospital Neonatal Intensive Care Unit, where infants at highest neurodevelopmental risk receive expert neurorehabilitative care while preparing for transition to home. Her research focuses on improving outcomes of high-risk infants through optimization of the NICU neurosensory environment within the family-centered developmental care framework. Dr. Erdei is an assistant professor in pediatrics at Harvard Medical School.
Callie, I think our listeners are really going to enjoy this. This time we have basically fortified knowledge going directly into their brain holes.
Incredible. Through an NG tube.
No NG tube required. We'll be good.
You're right.
Thank you, Dr. Erdei. Thank you for coming on to the show. Because we're an informal group, is it okay if we go by your first name?
Absolutely.
Excellent. So it's Carmina, is that correct?
Yeah.
All right. Carmina, since this is the first time you're on our show, I would love for you to sort of introduce yourself to our audience, to tell us a little bit about yourself, maybe something outside of medicine that you love to do.
Well, first of all, thank you so much for inviting me. It is a great pleasure to be here. And a little bit about myself. I am a physician scientist. I am board certified in pediatrics, neonatology, and developmental behavioral pediatrics. And my overall professional goal, both from a clinical and an academic standpoint, is to understand, study, and if I can, to improve the neurodevelopment of at-risk infants through early interventions. I'm also a wife and a mother to a very witty 12-year-old daughter who teaches me something new about parenting pretty much every day.
I have a 13-year-old, and he pushes me every day to learn something new about how to parent. So I totally feel you.
Yep. They make the best teachers.
Absolutely.
My child's never going to turn 13, right? Is that how that works? I don't know. Actually, let's skip all of our extra questions, and listeners know that we ask some questions that are pretty common. But having said that, we have such a big case. We have such a good topic. We have such a great guest. Callie, if you wouldn't mind just taking us right to our Cashlack case, and we'll just take off from there.
Yeah, sounds great.
It takes heart to build bodies that break records. And over the last 6 years, a team of incredible healthcare professionals did what most people thought was impossible. They rebuilt the body of legendary Olympian Lindsey Vonn after a series of devastating injuries forced her into early retirement. Now, she's headed to the 2026 Winter Games, ready to break records once again. This February in Milan, Lindsey's team and the entire USA medical team will be wearing FIGS. You can rock their official uniform too. The new Team USA collection from FIGS is engineered with FiberX, their most durable fabric yet. FiberX is setting the new gold standard for high-performance scrubwear. It's lightweight, breathable, and ultra-resilient. And of course, the styles come in red, white, and blue. So, listeners, check out the limited edition Team USA collection and get 15% off your first order at wearfigs.com with code FIGSRX. That's wearfigs.com, code FIGSRX.
So Anna is an ex-24-week baby girl who is discharged from the NICU at 47 weeks corrected gestational age. She has returned to clinic for her first appointment. She is now 3 months corrected, which is 6 months chronological. She went home with a nasogastric tube, taking about 50 to 60% of her feeds by mouth. She has mild bronchopulmonary dysplasia and does not require any respiratory support. Her NICU course was complicated by medical necrotizing enterocolitis at 3 weeks of life, bilateral grade 3 interventricular hemorrhage, and a patent ductus arteriosus, ultimately requiring device closure. Her subspecialty follow-ups include ophthalmology for bilateral stage 2 retinopathy of prematurity requiring laser eye surgery, cardiology for her PDA, neurology and neurosurgery for her interventricular hemorrhage. Her only discharge medication is polyvisol with iron. She takes maternal breast milk fortified to 22 calories per ounce. So this is a lot, but I think, kind of a story that we're kind of accustomed to hearing from our 24-week babies. Carmina, for a baby who will likely follow with multiple subspecialists like Anna and with her pediatrician, what role does NICU follow-up clinic play in her early life, and how does this differ from what her pediatrician might do?
That is an excellent question, and a great case that I think exemplifies patients in our practice as neonatologists and probably as primary care pediatricians as well, right? Invariably, we're going to be taking care of those former preemies who spend a long time in the NICU, usually several months, go home with multiple specialties. And what do we do afterwards, right? So from a NICU follow-up standpoint, the NICU follow-up clinic is a specialist clinic. So the same way children are referred to cardiology or pulmonology or any other specialty, the NICU follow-up team consists of an interdisciplinary team of specialists that add a complementary role to everything that the pediatrician is doing, which is very comprehensive, but in a very short period of time. And so I think everyone working in a NICU follow-up clinic should see themselves as a support and a partner for the pediatrician. And what we bring to the table that is unique is that neurodevelopmental framework through which we conceptualize the follow-up care of the NICU graduate to really optimize their functioning within the family unit, right, for the child and for the family. So what it looks like early on, it may be a lot of specialized support with feeding and growth. For example, like for a baby like Anna, as you were describing, she's a tiny former 24-week micropreemie who has done a fantastic job during the NICU stay and now is going home, but this is sort of just the beginning of the road of a new chapter, right? She still has extensive catch-up growth to undertake, as well as, feeding milestones that are still ahead of her. And a lot of the times, the pediatricians look to us as the NICU follow-up specialists for guidance with what are the appropriate types of nutrition, calories, fortification, for this child, and how do we work within the family's goals to make sure that they accomplish them? What is the appropriate growth trajectory, right? And it's not a one-size-fits-all. Oftentimes that has to be tailored and individualized to the patient. And as those patients grow and develop, right, the feeding and growth are some of the most important milestones, among others that are beginning to develop in infancy. And as children grow and become toddlers and later on preschoolers, we sort of shift that focus from feeding and growth, which is hopefully improved by that time, to also focusing on their neurodevelopment and their integration within the family. And what other interventions are occurring at that time? What other potential hospitalizations, procedures, surgeries that medically complex child may need? And how does that play into how they're progressing from a neurodevelopmental standpoint? And what can we do as professionals? How can we guide our collaborators from early intervention programs to best support that particular child within their, capabilities to really get to their best potential? So it really is the NICU follow-up program has this unique opportunity to contribute a specialized piece to the overall comprehensive care of the medically complex NICU graduate.
Thank you. And you mentioned interdisciplinary. So I wonder if you would share kind of what specific roles are in your clinic, like what kind of therapists, what additional resources do you typically have in a follow-up clinic?
Absolutely, I'm happy to. And I will preface this by saying that the NICU follow-up care tends to be very variable, right? And different institutions will have different components to their interdisciplinary teams, depending on many factors. In our clinic where I function at Brigham and Women's Hospital, we have a neonatologist-led team. So there is a medical provider that's usually a neonatologist. At times, it may be a nurse practitioner or working collaboratively with a nurse practitioner. And then we partner with specialists like feeding therapy and dietitians. Those happen at the post-NICU initial, what we call medical visit, and at the 4-month visit, any interim visits, so very frequently during the infancy time. Starting at about 8 months post-menstrual age or adjusted age, we start collaborating with our therapy colleagues, and that's usually a physical or an occupational therapist who, in addition to the medical and, if needed, feeding and nutrition assessment, will do a developmental assessment. I'll go back to say, starting at 4 months post-menstrual age, we start partnering with our therapy colleagues, and there's usually a physical or an occupational therapist that joins the medical and feeding and nutrition team. And we start performing neurodevelopmental assessments. And then starting with 12 months post-menstrual age, we move to performing the Bailey assessment. That's usually done by a child psychologist or, again, by a physical or occupational therapy colleague.
So you gave an amazing summary of what the NICU follow-up clinic does. It sounds like we start with the growth. That's the first thing that you guys focus on when the babies come to you initially. And then once we kind of get to a good growth standpoint, we start more into the neurodevelopmental milestones. So let's talk a little about growth. So to very begin with, I guess we'll start super basic. Like, what growth curve do you even use for these preterm infants? And then how are you assessing the adequacy of the baby's growth? Are you using this growth curve, or do you want them to cross to a growth curve that is more along the lines of a full-term infant? And kind of take us through how that works.
So I think the first thing to say is that there is still debate regarding what is really the best approach, right? So in that sense, I don't know if there's necessarily a right or wrong answer, and there may be different practices that different institutions are agreeing upon. In the institution where I work, we generally make these decisions collaboratively with our dietitians. We're fortunate in that we collaborate very closely with dietitians throughout the NICU hospitalization. And then at the time of discharge, our highest risk babies are actually followed in a virtual transition to home program, which follows the highest risk candidates every week until they transition to the traditional NICU follow-up clinic. And that's usually a pediatrician that's specialized in the care of the medically complex former NICU graduates, partnering with feeding therapy and dietitians. How do we make decisions about feeding and specifically caloric intake that are required are based on growth trajectories. You asked about growth curves. In the NICU, we generally use the Olsen growth curve for infants who are born preterm up until term equivalent age or 40 weeks of gestation. And then after which time we transition to the WHO 0 to 2, boys or girls, always corrected for prematurity at this stage. Now, again, I said there's no right or wrong answer. For example, I'm also a researcher, and in my research projects for consistency with what we're doing within our research lab and collaboration with other colleagues, we used the Fenton growth curve for standardized measurements. In terms of when to make a decision to adjust calories, whether it's going up on calories or going down on calories or increasing opportunities for breastfeeding, which is unfortified mother's milk, those are made based on the growth velocity. So our dietitian colleagues will calculate the rate of growth in terms of grams per day for certain periods of time. And when the growth is within our target range, whether that's 25 to 35 grams per day, depending on the age of the baby, or a little bit less for older infants, when we reach that trajectory for a sufficient period of time, then we go to the next step lower. So, for example, just providing an example, say if Anna was having 4 unsupplemented breastfeeds at some point in her trajectory, and was taking 4 fortified bottles of express mother's milk with additional additives, then we would go down to 2 bottles and increase opportunities for breastfeeding by the equivalent amount, and sort of take it stepwise by 1 to 2 feeds every couple of weeks until we reach the family's goal, which a lot of times might be exclusive breastfeeding, and that's fantastic. That's what we wish for every infant, every preterm infant as well. Or not. It may be, just going to unfortified feeds of breast milk or formula, depending on what the family's goals and preferences are.
So I want to follow up a little bit about the actual growth trajectory and what our average expectation would be, because I actually want to use some real numbers for us. And I know every case is different. And so this is where it's going to be a little bit challenging. We are going to talk a little bit about different types of formulas and things like that. But before that, I want to kind of get at either grams per day, kilocalories per kilo per day, or like percentiles that we're shooting for. Is there one of those things that when a patient leaves the NICU or general pediatrics and is discharged home, that there was a whole reason why there was, usually a dietitian in the hospital that got you to that number. But when you are discharged, and maybe if you're in general pediatrics and you don't have access to NICU follow-up clinic, and these are the types of specialty things that we'd love to teach ourselves, what are we going for? Are we trying to get to like the growth trajectory, trying to get to like 50th percentile for the that corrected gestational age? Are we trying to just do 30 grams per day? Are we trying to do 130 kilocalories per kilo per day? Like, how are you thinking about this when they first come out? And then obviously everything's individually adjusted afterwards.
Right. That is an excellent question. So, starting with the first one, are we always shooting for the 50th percentile? I would say no, right? Because how many of us are realistically exactly at the 50th percentile in terms of any of our measurements, right? So I think the goal is what that baby's appropriate percentile is matching what they were when they were born. So a lot of the times a baby might be born at a certain percentile with, let's say, the 25th. They might drop, after birth, that's expected, 10%, oftentimes more if they're premature, and then gradually getting back. Our goal is for them is to get back to the 25th or somewhere around the percentile where they were born, and stay there and grow gradually. So a lot of the times the calories, including the total kcals per kilo per day, are adjusted by our in-house dietitians in the NICU, really targeting where that particular baby should be, right? For example, for a baby who is born, at the lower percentile, we want to get them back to their own percentile. We do want for them to be able to do some catch-up growth, but we should remember that should happen over the course of months and years, right? We don't want to overshoot. We don't want too much too soon. So that's the percentile. I think the number per se is individualized to the baby. And no, we should not go for, the goal shouldn't be getting everybody to the 50th percentile as a sort of a universal goal. Now, how much should a baby grow in terms of grams per day? The goal for babies who are in the first few months of infancy is 25 to 35 grams per day. So up until about 4 months of age, that's our goal. After that, it changes more to, around 20 grams per day is the goal as an average. So if a baby is growing 28 to 30 grams a day over a period of a couple of weeks, of several weeks, and is really growing within the goal, or growing above the goal, then that's our cue to start weaning calories. And sometimes that happens, at a few months of postmenstrual age, but sometimes for some babies that happens earlier. They might even be in the NICU when we're realizing that they're growing so well that we don't need to add all the additional fortifiers and additional calories, and we start gradually coming down on the amount of supplementation that they need.
Awesome. And so that's perfect, right? We can adjust what we need to do as long as we know what our goal is. And it sounds like baseline goal, for the general public is roughly the percentile that they came out at. And if we can do that, then we can adjust as we go. And just to clarify, you were talking about the first 4 months of life, roughly 30 grams per day, and then dropping to 20. Is that first 4 months chronological age, or is that corrected? Gestational age?
Yeah, another great question. So whenever we talk about milestones for preterm babies, it always goes by corrected age or adjusted age, with the exception of vaccinations or immunizations, which should always happen at the chronological age, just because we know that they have the capability to mount an appropriate immune response at the respective chronological ages. But everything else, including feeding and growth milestones, should go by adjusted age.
Awesome. Probably should have asked that in the beginning. Yeah. But now we're getting to this. But all right, great. All right, Callie, take it away.
Yeah, that's so helpful. Thank you. And you talked about fortified, either fortified breast milk or formula. So I know there are, fortifiers and also some preterm formulas that we'll see in our babies. Can you share why preterm babies are on specific preterm formulas or fortifiers? Like, why is that important for a preterm baby?
Another great question, Callie. So preterm infants have different types of metabolic needs for growth and catch-up growth compared to term infants. So the preterm specific the preterm specific products, the formulas, are formulated such that they include not only additional calories with overall calories and protein and fat that is really important to support that catch-up growth, but they also have different proportions of minerals such as calcium and phosphorus, which is important for bone growth, as well as other nutrients like vitamin D and iron. And again, those are specifically formulated with the needs of preterm infants in mind. What the term formulas are formulated that is specifically for term-born babies who may not have those nutritional deficiencies that preterm babies do.
Thank you. And in a baby, so they kind of start on this preterm formula or fortifier. When can a baby transition to like quote unquote regular formula or to breast milk without any additional fortifier? Like outside of the caloric needs, when can they graduate from those special, micronutrient different formulas or fortifiers?
Right. So one general rule of thumb, which again might not be applicable to absolutely all preterm infants, but when an infant is ready to go to 20 calories, then we generally do consider a term formula because of, also thinking about, accessibility for families and pricing and all the other barriers, right, that are part of that complex decision making that we make, that we consider for each case. So generally, when a patient comes to the point of being ready for 20 calories, we ask the question: is this baby ready to go to a standard term formula or to unfortified breastfeeding, which we assume is 20 kcal per ounce, but we don't yet have ways of proving that. That is true, across the board. Some babies grow fantastic on just mother's milk, and that might be more than the 20 calories for all we know. And until we test it, we won't know for sure. I would say the exception to that is there may be infants who are particularly at risk. Those are infants who are born either with intrauterine growth restriction or small for gestational age, or they may have other conditions that lead to increased metabolic needs, or for whatever reason, they may have, metabolic disease or bone disease. There may be infants who still require that higher mineral and nutrient density of preterm formulas. But as a general rule, if a baby is ready to go to 20 calories, then and especially if there is enough mother's milk available through breastfeeding or express breast milk, then we absolutely want to try to move in that direction. And like I said, sometimes that might even happen before NICU discharge for some really well-growing, overachieving even for little micropumies, that can happen, that moms can go home exclusively breastfeeding or providing express breast milk to their, former 24-weekers.
Now, speaking of affordability, you said for preterm formulas and fortified formulas, these are things that can be gotten through WIC if it exists in the future when this podcast comes out?
Yes. And hopefully, yes, that will continue to be the case for the future. There absolutely should be. I am, of course, speaking based on my experience. I work at a large academic urban center. There certainly could be access issues for other patients, I can imagine. So in those circumstances, I think, one of the other roles that we all have as pediatric providers is what is the best access we can facilitate and the best plan for this patient and family, and how can we advocate for it? And there may be cases when that is absolutely necessary, and then it becomes our job to make that available through whatever means we have possible for that family. Or there may be situations where, it's a little bit of a gray zone, and maybe we can do a trial. And if things go well, then that's great. And the baby has made the step forward in sort of standardizing the feeding plan. But if it doesn't, then again, we need to take the next steps to ensure access, because growth is critically important. And it's not just grams. It's not just the actual weight, right? It's length, because we know that does correlate with ultimately the height potential of these NICU graduates. It's head circumference. So good growth also means brain growth, which supports optimal neurodevelopment. So all of that all of those are important reasons for which we should advocate for the right nutrition plan for each infant.
You know what really eats up time when you're running a small business or side project? Payroll and HR. I've had days where a quick admin task turns into hours of forms, logins, and double-checking tax stuff, and I remember thinking, there has got to be a better way to do this. That's why I'm a big fan of Gusto. Gusto is online payroll and benefits software built for small businesses. It's all-in-one, remote-friendly, and incredibly easy to use, so you can pay, hire, onboard, and support your team from anywhere. What I love is how much it automates. Payroll tax filing just happens. Direct deposits are simple. And all the onboarding paperwork, offer letters, forms, everything gets handled in one place instead of scattered across my inbox. Plus, you get unlimited payroll runs for one monthly price, which means no surprises when things get busy. And if you ever have a tricky HR situation, Gusto gives you direct access to certified HR experts, which is honestly a huge peace of mind. And so, if you're ready to save time and skip the admin headaches, try Gusto today at gusto.com/Cribsiders and get 3 months free when you run your first payroll. That's 3 free months of payroll at gusto.com/Cribsiders. One more time, gusto.com/Cribsiders. And you mentioned for preterm formulas for these, early preemies that's what their gut needs, that's what the micronutrients needs, that's what their brain needs, that's what their development needs. If we still need 22 kilocal formula, for example, is there any downside for the, now 4-month-old to be on a a premature formula in that way? Or it's just Term formula is just it's just a little bit cheaper, but otherwise there's no downside. It's like the gas. And that's what I'm trying to say. It's like gas. You can definitely put the high, the expensive gas into your car all the time. It's just that the cheap gas can't go in when you need the expensive gas.
So I think the answer to that is really dependent upon how much catch-up growth has the baby made and whether that is still metabolically necessary. And I would say there is a point where for some babies, they have done such excellent catch-up growth when those additional micronutrients and vitamins and minerals that are added to preterm formula are just simply not necessary. So I think when we reach that milestone, the transition should be made to regular term formula or to unfortified express breast milk. If the mother has breast milk, then the benefits are clear. And yes, of course, we should transition. If it's a preterm formula versus term formula type of question, I would say that still we should make the transition, because if the baby no longer needs it, then why would we want to give them a cocktail that has all these additional items added to them when they may not be necessary, right? I think we have had in neonatology a history of doing too much too soon, right? And we don't want to overshoot in terms of providing too much nutrition, whether that's too many calories or too many micronutrients, because what we were aiming for is a normal metabolic rate. And we know that cardiopulmonary outcomes are a big focus now in terms of looking at outcomes of preemie babies. They are at risk for a number of metabolic imbalances further down the line. So anyways, all of that is to say is that if we reach a point where we can comfortably say the baby no longer needs that additional fortification and what the preemie formula is providing, then that's perfectly safe to transition to term formula and actually indicated, and a little bit cheaper for the family. So why wouldn't we go ahead?
Thank you. And I had one last question, regarding formula. So if we're on these, more calorically dense feeds, either fortified or on a, calorically dense formula, 22, 24, 27, are there any adverse effects we should think about, like, more spitting up, like more, constipation? Do we see that with these denser formulas?
I would say we see that fairly often. I see that fairly often in my practice, and I would say in our clinic and in our NICU, that does tend to be pretty common. I think, the jury's still out there, whether it's the formula that's necessarily bothersome to the baby or the fact that the baby is born with an immature gut, right? Preterm babies are immature head to toe, including their gut, their digestion. And then, their gut is not supposed to be functioning. And then we're blasting it with high calorie, milk and all these other additives. So, of course, a lot of babies in the NICU will be, what nurses might say, or everybody in the NICU, the baby's grunting and groaning and has spit ups and intolerance and, loose stools or constipation. So yes, that's definitely very common. It's oftentimes common in the NICU, but it's actually more often in my experience that babies are doing okay in the NICU, particularly because in our unit we use the human milk fortifier, which tends to be extensively hydrolyzed, and it's a little bit better tolerated. And then we move to the transitional formulas for home, and those are more intact milk protein and harder to digest. So we actually see quite a few feeding difficulties and feeding tolerance issues for babies right after they go home, and then when they come and see us in the NICU follow-up program for the first time. So I want to say one of the things that has helped is in our transition to home virtual follow-up program, we tend to see these difficulties earlier on. And we actually, for those babies, start doing more sensitive formulas fortification, even at the time of discharge from the NICU, if that is appropriate from a growth standpoint. So again, we need that dietitian expertise to be able to say, yes, for this baby, it's safe to do a sensitive formula as opposed to the preemie formula. Whereas for others, they may say, no, we really need to prioritize growth here. And I would say in the follow-up program, when we see babies for the first medical visit or sometime in between that NICU discharge and 4 months post-menstrual age, we do have quite a number of infants for whom we have to change the feeding plan from that, optimal fortification with a preemie formula to something that's a little bit more hydrolyzed or broken down. Those are your specialized, extensively hydrolyzed formulas. And even a step further down, those are the elemental formulas that can be either taken by themselves or added to express breast milk for babies with either severe gastroesophageal reflux or a lot of feeding intolerance. For me personally, and the way I explain this to families is that the threshold for making a change is usually if the discomfort is that significant that it really interferes with the baby's feeding behaviors, the quality of feedings, or it impacts growth, which in some cases it can. So those are definitely issues that are very common for those of us seeing young babies in the follow-up program.
Yeah, because I was going to follow up and say, how do we troubleshoot this? So it sounds like we have often symptoms that are some sort of, feeding intolerance / discomfort that comes with this. It sounds like the best way to do it is to kind of essentially go to more hydrolyzed formulas. But it sounds like what you're saying is the downside is the hydrolyzed formulas that we have are only term formulas, and we don't have preterm hydrolyzed formulas that have the micronutrients that we need. Is that a correct interpretation? Exactly. And said, okay. And so then we try to balance, can we switch them to a term one? And sounds like you asked the dietitian for that assistance. Just out of curiosity, is there a corrected gestational age cutoff where you would feel safer about this versus something else, just for us if we don't have a dietitian nearby?
So I don't think that it's necessarily a question of the age, right? Okay. Especially if the baby is post-term, right? Post 40 weeks. I would say that's more so for babies who are still preterm. They're still before their term equivalent age. I think that would be more of a concern. Once babies get to be term equivalent age and older, and they have a satisfactory growth curve leading into that age, I think the question becomes, what are the risks and benefits, as with everything, right? And on the one hand, we might have the happy spitters who are, spitting up a lot, but they're still happily eating and they're still happily growing. In which case, we just educate the parents about the gut immaturity, and we try to stick it out to see if over time, the reflux, which is, I say, normal in all preterm babies, right? Because they're on an essentially all liquid diet, they're lying back to sleep all the time. So of course, and they have an immature sphincter. So of course, some of the stomach contents are going to reflux up the esophagus part. That's normal and physiologic. It's what is no longer normal, right? Is that spit up, that reflux, or is that discomfort so significant that it interferes with the baby's ability to drink all their bottles and all their calories and their ability to grow, right? Then in that case, well, if they can't really take their feedings and they're not growing appropriately on the ideal nutrition, then we have to make a change, right, to get them closer to where that goal is. I will also say that we're dealing with a very unique population. And sometimes these feeding discomfort symptoms, oftentimes they're due to the immature gut, to maybe some reflux, which again, in part, some of it is normal in all preterm babies. Sometimes it gets to be abnormal when it's associated with more significant symptoms and might need some treatment. And there is a small subset of infants for whom those are symptoms of maybe a bigger problem. And that is dysphagia. I would say that's also very common in this population. That may manifest through, again, a lot of feeding intolerance, and also babies' behaviors of starting to not want to take their bottles, push away their bottles, turn away. They may be coughing or sputtering during feedings. They may be just gradually becoming more disinterested and not having energy in taking their bottles. So something we always keep in the back of our minds, and then we pull on the expertise of our feeding therapy colleagues is this baby at high risk for aspiration? Have we reached the threshold to consider a modified barium swallow study to evaluate for aspiration? So that's the one caveat we want to keep in mind, that, sometimes those feeding intolerance symptoms might mean different things in different patients. And certainly the case that Kelly presented would be a great example of a baby who's at highest risk for aspiration for all the reasons: prematurity, PDA closure, prolonged hospitalization, BPD, all of those issues. So,
Carmina, just an additional question about your micronutrients. So this baby, our baby Anna, went home with polyvisol with iron. First of all, how long would you recommend a preterm infant stay on a multivitamin? And then at what point could you move to kind of the standard vitamin D and iron that any term infant would be on?
Thank you, Kelly, for that question. So again, the needs of each baby are individualized. I think what I see very often in our population is that babies have to have separate vitamin D and iron just because during the NICU hospitalization, they actually require higher doses of each, and they have to be better tailored. As you know, polyvisol with iron only comes in one concentration, right? And if you increase it, then you increase both. And if you decrease it, then you decrease both components. You can't really adjust the vitamin D and iron separately. So I think it really comes down to that. If the dose is appropriate, we generally aim for a mix of iron per kilogram per day. And we think, some of it comes from the formula and some of it comes from supplementation. If what's available commercially in terms of a polyvisol with iron concentration is appropriate for a baby at the time of discharge from the NICU, then absolutely do the combination. That's a lot easier for families to remember one versus two different products. I would say what happens oftentimes is that they either require more iron, or the iron that's available in the polyvisol with iron formulation is too high to administer the combined product, or even if you do half an ml, then that's not enough of vitamin D, and so we have to do the separate products. And then in general, how long do we continue them for? Vitamin D should be continued until baby takes about 1 liter of formula a day, or about 28 to 30 ounces. And then iron should be continued, especially if the baby is primarily breastfeeding or taking primarily expressed unfortified breast milk, generally until they take a significant amount of solids that are fortified with iron, and then they can come off the fortification or the additional supplementation, rather.
Thank you. That was perfect. Okay, so we've talked about growth and how important that is for a baby's development ultimately, and for their both physical and developmental health. So I want to kind of shift gears and think more of that neurodevelopmental monitoring and kind of that important aspect of follow-up clinic. So I just want to start just by asking, what tools do you typically use to assess an infant's developmental progress, like in NICU follow-up clinic?
That is a great question. And yes, I'm very happy to share our clinic experience. I will say that if you survey, a number of NICU follow-up providers from across the country, you're probably going to get quite different answers. And that's partly because our tools are relatively limited at this very young age to reliably assess neurodevelopment in a way that is stable and predictive of later functioning. And so it is very common that NICU follow-up programs will adjust their evaluation and developmental evaluation battery based on what expertise they have available and what works for their population, for their decision-making processes, and what have they found that's helpful to families. So, for example, in our clinic, we start more formal developmental assessments at the 4-month postmenstrual age visit. I will say that we always have an informal assessment, right, of a child's development, functioning within the family at every single visit, right? That's part of what we do as NICU follow-up specialists. But in terms of separate dedicated neurodevelopmental assessments, we start that at 4 months postmenstrual age in the follow-up clinic, and we start with an assessment that's called a TIMP, or the Test of Infant Motor Performance. We then follow it at 8 months, corrected gestational age, with a Bailey screener, the Bailey 4 assessment. I think the Bailey is probably pretty ubiquitous, I would say, in our NICU follow-up programs. It's been used for a long time. We do have a relatively recent version. It's been updated not too long ago, just within the last couple of years. And that's traditionally one of the outcomes that's very commonly looked at in neurodevelopmental research, outcome research. And then we continue with doing actual, the extended Bailey neurodevelopmental assessments at 12 months postmenstrual age, 18 months, 24 months, and then once again between 30 and 36 months, at which time we generally transition infants to other longer-term pediatric neurodevelopmental centers if there are ongoing difficulties or needs and patients and families require ongoing support. In addition to these standardized assessments, we also do a number of questionnaires, which again, I think are pretty common. We do the Ages and Stages questionnaire at every visit. We do the MCHAT at the 18 and 24-month visits, and even the 30-month if the child still qualifies. We do a strength and difficulties questionnaire. We do a feeding screening for older children who don't automatically get to see the feeding therapist unless if they didn't have a pre-existing feeding problem in infancy. So that's usually our battery. Now, you might ask a follow-up question, is this really the right thing to do? Are we doing things perfectly? And of course, there's always room to improve. I would say these tests are relatively common in NICU follow-up. However, I think we live in a day and age where, especially in the post-COVID era, we've learned a lot from families about what really matters to them. And I do think we're at the point of inflection in the follow-up world where we will have to be more cognizant of that particular need, and we will have to listen more carefully. So I think that the follow-up has gone so traditionally in a sense of these are the standardized assessments we do at these particular ages, and this is what we have to do at this visit. And I think what the future holds for all of us is getting to be more in that listener seat and getting to the point where we can ask families, what's important to you? What are you trying to get out of this visit? Maybe that cognitive standard score on the Bailey means a lot to me because I need to, use it for X or Y reason. But is that important to you? Or is there something else that's really important that we can help you with so that your child is better integrated in your family, that makes your day-to-day life easier, or that helps you better understand how to help your child do their very best? So I think, this is where we are, but I wouldn't be surprised if we have this conversation again in a few years. I would want to hope that the answer might be different and might be, a little bit more patient and family oriented, not based on, what we do at our institution or another institution. Just in general, I think conceptually we're at the point of inflection where these sort of standardized, rigorous plans are about to evolve.
And I was going to ask a follow-up question to a part you said earlier, but it kind of relates to what you were just saying about being a little bit more patient and family-centered. We know that Anna, our patient, is born at 24 weeks, probably as due to the prematurity component was certainly be the highest risk. I was going to say, does that even matter in the sense that you're going to do the exact same questionnaires and the exact same steps and do the exact same thing for every single baby that comes through NICU follow-up clinic? Or do kids who are higher risk get something else that we should know about?
The way I think about prematurity, and I think what research has taught us, is that prematurity is a lifelong condition, right? It arises in the context of an abrupt, interrupted pregnancy, which means abruptly interrupted brain development and overall physical development, followed by a separation from the family unit, babies quickly whisked to the NICU, placed in a plastic box, separated from their family, and then they live there for months, such in Anna's case, right, until they get somewhere around term age or maybe a few months post-term, where they finally get to go home, right? So all of those, that interrupted early development and all of those months of development within the hospital environment with all of those neurosensory stimuli that are very different than the biologically expected experiences that a baby should be undergoing, whether in utero or, born at term and going home with the family, do have a lifelong impact. So in the grand scheme of things, I would say the fact that Anna was born early at 24 weeks really does matter, right? She has started her life in the context of that family trauma with that prolonged hospitalization that in and of itself is a traumatic event for her and for the family. And that puts her at lifelong risk of neurodevelopmental challenges. Now, the thing is that we don't have great tools to really outline those very accurately when babies are infants and toddlers. Or not yet, anyways, not with the technologies we have available for everyday clinical use. Now, more is coming. There's a lot of neuroimaging. There's a lot of, research that's being done in terms of, other types of neurobiological assessments that might teach us better. But right now, if I evaluate Anna when she's 12 months of age, I cannot tell you what type of learning difficulty or learning disability she might have at school age, or not yet, right? I think what really matters is making sure that we are there for that infant and that family, and helping them understand that they, as the family, are essentially medicine for their child, that they will always have to be their advocate. And that we will always have to have kind of a lower index of suspicion because of prematurity to suspect that a child Anna or any other similarly preterm born infant might have a difficulty that could be related to the history of prematurity, and to have a low threshold, so high index of suspicion and low threshold to activate supportive services. What that could look like in infancy may be, advocating for the most intensive early intervention service plan that can be helpful to that particular infant. And a lot of the times, early intervention services, they're state dependent, and the criteria to qualify is actually quite stringent, right? The bar is set pretty high. And for some of the, what I call overachieving little preemies, they may be doing so well on those assessments that they may not even qualify for supportive services. So that's where the prematurity as a risk factor, along with other risk factors that are important in the eyes of early intervention, and as they should be, for example, IVH or need for surgeries, all of those could constitute risk factors that help us as providers advocate for the most optimal support we can for those patients. I would say wherever you practice, make sure you're aware of what those eligibility criteria are and how we can use those terms to communicate with our colleagues in early intervention to advocate for that child. Other factors that are really important for us to keep in mind are family social risk. And again, that should be, that in and of itself is a risk for neurodevelopmental potential challenges, even in term-born babies. So families with family social difficulty or vulnerability have, they do have an additional risk factor, and that should be something we need to consider and communicate when advocating for our family's needs. And then I think in general, the social determinants of health are important to evaluate consistently, because we want equity for our families in terms of access to services, right? And difficulties in whether it's financial difficulties or their barriers to care, to follow-up services, all of those can have an impact on a child's overall well-being as well as on their neurodevelopment, and should absolutely be thoroughly assessed in her case and in every patient's case.
Do you feel like you can never get ahead of charting? Imagine a world where you don't need to think about notes again. Introducing Freed, an AI medical scribe built to free clinicians everywhere. It listens, transcribes, and writes instant clinical notes for you in your style. Freed can be used across all specialties for in-office as well as virtual visits, and it works in multiple languages. Written in your style and ready the moment the visit is over, all you have to do is copy it into your EHR. Freed is HIPAA compliant and only takes seconds to learn. Over 15,000 clinicians, including doctors, APPs, therapists, use Freed to save up to 2 hours every day and free themselves from that documentation. Just imagine the great feeling of coming home without any notes hanging over your head. Get back to doing what you love and let Freed do the rest. And start your free trial today, no credit card needed. Use code CURB50 to get $50 off your first month when you subscribe. That's code CURB50 to get $50 off your first month when you subscribe.
And what advice was just in any baby, it's their day of discharge, what advice would you give them? And families are asking, hey, what can we do at home? What can we do to help optimize our baby's developmental outcomes? What advice would you give to that family? Like, what would you tell them?
So again, I tell every single family, every one of my families when they go home, you can do so much for your child. You are literally medicine for your child that we as medical care providers cannot give them. And that goes for when their baby is in the hospital and so much more, even so after the baby goes home. I think the most important, sort of some of the most important things that families can do with their babies are the quality time they spend together, the quality of their interactions, how much time and availability they're able to offer that child to really engage with them, whether that's through ongoing skin to skin, right, which shouldn't end at the time of baby's discharge from the NICU. That absolutely should continue at home. Doing things like holding babies, learning their cues, learning to recognize that quiet alert time that babies exhibit, and building on that, right? Using those moments of quiet alert time to engage with their babies, whether that's through reading with their baby or singing with them, or just talking with them and creating back and forth interactions, recognizing their first vocalizations and responding to them, kind of building that back and forth volley of sounds, especially as they get a little bit older and they start cooing and then vocalizing. All of those are the building blocks for later learning. And so when families are going home, I want to be encouraging, and I want to reassure them that everything they've been doing with their baby, they should continue to do at home because it matters so much. And I oftentimes say babies are sensory learners. They literally learn through their senses, right? So everything they hear, things they see, things they smell, things they touch, all of those things are teaching their brain and their nervous system how to interact and how to respond to the world. So capitalizing on all those interactions, on meaningful interactions, on talking and reading and singing, doing as much of tummy time as the baby can tolerate, practicing all, the safe sleep and all the general guidelines we give families at discharge. All of those things are so important. And then I'll say, we're right here with you, right? This is the beginning of a new journey for you. It's in many ways and in many cases really scary. Parents never feel ready, right? There's always some expected anxiety about taking home your baby from the NICU after, dozens, sometimes hundreds of days in the NICU. But we are here with them as providers, right? They know how to reach us. They should trust their instincts. They know their baby is the best. And when something just feels off or feels like is not going in the right direction, they should know who to reach out to for more support.
And kind of the final treatment piece, we've talked a lot about this actually already, but we want to provide as much developmental services as possible. And often through the way our healthcare system is set up, early intervention is a great option for most people. Offers very easy to refer to early intervention. Sounds like it's a little harder by state to actually get the services that you think you need. And that's where, NICU follow-up clinic can be really helpful about advocating for them. I'm going to flip this question a little bit the other way. Are there any babies that are discharged from the NICU that I should not refer to early intervention? I feel like the answer is just refer everybody and then we'll work on how to get them the most services. Are there anyone I should not refer?
So my first intention is to say no. In my opinion, early intervention is always beneficial, and more developmental support and developmental guidance is always better. If, for nothing else, then it's for that parent education and parent empowerment piece. Now, I will say that, again, there are strict guidelines. In our state, every baby who's in the NICU for more than 5 days is eligible to be referred to early intervention. So someone might say, oh, this baby was born at 34 weeks. Should we really refer? And what I say to them is they've been in the NICU for 3 weeks or 4 weeks. They're going home seeing a couple of specialists. I would say refer. And, they in that evaluation, there may be a role for ongoing early intervention support, and that may be offered to them. So I would say always refer if it's in line with your state guidelines. The other thing I tell families is that even if we make a referral and your baby doesn't qualify because they absolutely rock on the test and they get all 100% on all the, 2 questions or 2 items that are being assessed in each domain, right? Babies don't do as much. So when we evaluate in infancy, chances are they might do very well unless they have obvious limitations. I will say, if you are worried at any future time, you should know that you as a parent can self-refer. You don't need me as a doctor or another healthcare provider to make the referral. If, say, in 4 months or 6 months, you really feel like something's not going well, should my baby be doing these things and they're not? Yes, there are a lot of educational resources and websites and trusted sources that we recommend and we give to parents, but they can also reinitiate a reevaluation to early intervention if they have a developmental concern. And then can be empowering to families knowing that, within the first 3 years of life, if I have concerns, there are multiple action mechanisms that I can activate to support my child if needed.
That's wonderful. I think even, in the evaluation process too, like someone comes out to your home and looks at your baby, even just the eval, I feel like you still get advice even then. So even if they say no, you still had a therapist come out and see your baby. Even if they don't need services, you've still had an additional touch point, and they can even give you recommendations right then. So that's such great advice. And I wanted
Absolutely.
to Yes, thank you. I wanted to, close with hearing a little bit about the growth and development unit that you run. It sounds incredible. So can you tell us kind of the target population and what you're doing for these NICU babies to kind of help transition them to home and help them develop even before they go home. I love what you're doing.
Thank you, Callie. So indeed, I run the Growth and Development Unit at Brigham and Women's Hospital, and we call it the GDU. And what the GDU is, it's a neurohabilitative program that is essentially embedded in a larger level 3 NICU. So we're level 3, 66-bed NICU. We're a referral center for a relatively large catchment area, and we work with our community partners. And we primarily take care of babies who are born either preterm, including all the extreme preemies and micro preemies. We have a very active maternal fetal medicine service with whom we work very closely with. And we also are a referral center for babies with neurological disorders, babies with hypoxic, with neonatal encephalopathy, and in general, other babies with, congenital or genetic conditions that need subspecialized support. So babies usually come to our ICU area for critical care. And when they reach the point of no longer needing to be intubated and on positive pressure support, but still requiring a relatively long convalescence period to work on feeding, growth, and milestones needed to be able to transition to home, then they get transferred to the Growth and Development Unit, or the GDU. So that's essentially a 20-bed unit that's embedded in the 66-bed NICU. It is intentionally designed to be to have a hybrid, semi-private space that's quite large, generous for each patient to allow for some more generous patient space, but it's intentionally open to create a more social environment for infants with more language exposure and more purposeful, opportunities for connection among families. And it does have a couple overnight rooms where families can room in when needed or before discharge to practice feedings, exclusive breastfeedings, and so on. So within the GDU, we work very closely with an interdisciplinary team. That's where we make all of that collaborative decision-making with families, with feeding therapists, with dietitians, with our social work and mental health colleagues who are so important and play such an important role in the discharge readiness and discharge planning for every family. And of course, we work with all of our medical consultants and specialists and really strive to get every family ready to take on that leading role of being the most important person in their baby's life and taking over the care of their baby so they can have a more seamless transition to home as much as possible. And I would say the patients who are often referred to us are either those who are born very preterm, so at 33 or below weeks of gestation at birth, or babies who have neonatal encephalopathy, who received hypothermia and are in a convalescent stage requiring more support, or babies with genetic congenital anomalies, other neurologic conditions. So in general, a population who's at higher neurodevelopmental risk.
That's incredible. And we always ask you, all of our guests, is there anything else that you want to plug before we wrap up? Any resources that you recommend for families or for anybody who takes care of NICU babies in clinic, or anything that you want to share with us?
I think you've touched on all of the important points. I think there are always lots and lots of resources we talk about in the NICU follow-up clinic, and that includes the Ages and Stages websites for a lot of developmental guidance, the Bright Futures resources. 0 to 3 website is excellent for developmental guidance. Reach Out and Read has amazing resources about language exposure, and we actually partner with Reach Out and Read in the Growth and Development Unit. We're one of those NICU programs and try to emphasize the importance of early literacy from, the time babies are in the NICU and then continuing after discharge with those healthy routines. Or again, early intervention, it is so important, and families knowing what it is and knowing that they can refer and self-refer even at a later time if needed. All of those are, I think, great, excellent resources for families. One additional thing I can add is that we're working a little bit backwards, but now in the most recent, I would say decade and a half, we've started to realize that we actually need developmental guidance and more structured developmental support plans for babies while they're in the NICU, right? If you think about all of our developmental websites, they're all created with the, expected milestones of term babies in mind. And now we're starting to see more and more programs that are specifically designed to teach parents what should a 32-week baby do and how much language exposure should that baby have, what should be the visual experiences of such a baby, the proprioceptive or tactile experiences, the olfactory experiences, and so forth. So, for example, in our unit, we use the SENSE program that was developed by Dr. Pineda, which is, widely available for use for, I believe, a nominal cost. It's not the only program. There are others available. And again, I think what's important is that we start talking that language with parents in the NICU, and we start educating them about, what every baby needs at every stage and how to communicate with their baby, how to read their cues and respond appropriately to them. So whatever, type of program fits the individual, unit and institution, whatever that program is, the more important thing is that we should be using a structure and a framework to start that neurodevelopmental education and active support while babies are with us for weeks and months in the NICU. Because if we wait to start early intervention when the babies are going home, we've missed a really critical window of intervention and opportunity that really should start as soon as possible after birth and working around the baby's unique medical needs and capabilities.
I love that. I will say our NICU also uses the SENSE program. It's really neat. We have little cards that, for each week it's by the baby's bed, and it'll share the 5 senses and what's appropriate. And I too think that program is so cool. So I'm glad you talked about that. Are there any just final take-home points that you want to share? Any, if listeners take away one thing, is there kind of one thing you want to just make sure we all remember or recognize?
I think the most important thing the most important take-home point as a NICU follow-up provider is that we are advocates for infants and children at neurodevelopmental risk. But really, we are there as a partner for the family. Because I really firmly believe that the most important therapist in a child's life is their parent and their family, right? That's where each child belongs within their family unit. And what our role is to help them really function the best way they can and meet their best potential within the family. We work together with each other, with pediatricians, with all of the medical subspecialists, and each one of us brings that little piece to help a child thrive really within their family.
That's amazing.
Thank you so much. I really learned so much today. This has been a lot of an area that has been, I sorely needed updated, so I appreciate you speaking to us today, and I'm very sure that our listeners got so much out of this. Thank you again.
This has been another episode of The Cribsiders.
It's for the kids!
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Dr. Callie Marshall, and our wonderful social media team on Twitter, X, Blue Sky, and Instagram, Deanie's Cruz. I've been Sam Mazer.
And I've been Callie Marshall.
And this has been Chris the Chew Man Chew. Thank you and good night. Hey, Callie, knock, knock.
Who's there?
Corrected.
Corrected who?
Corrected age is what we'd use until you're 2.
That's beautiful.